Thank you, program directors. While I'm busy talking, can I ask the panelists to please join me on the floor in the essence of time. Next up, we have only lady in our panel today, Professor Mulaudzi. Prof. Mulaudzi holds the South African Research Chair in the Ubuntu Community Model in Nursing at the University of Pretoria, where she also serves as Professor of Nursing Science and with over 42 years of professional experience. And she is recognized as a distinguished leader in nursing education, research, and healthcare transformation. Her scholarly work includes ethics, human rights, HIV/AIDS, reproductive health, and integrating indigenous knowledge systems into health sciences. Welcome, Prof. And last but not least, Mr. Wright, Mr. Gavin Wright. Mr. Gavin Wright is a safe patient handling consultant with extensive experience in emergency care in both the UK and South Africa. He has obtained qualifications in moving and handling instruction, risk assessment, health and social care management, and accident intervention and investigation. Involved in moving and handling since 1993, he formed a training company and was instrumental in developing accredited courses for instructors in patient handling, including the first diploma level course through Oxford and Cambridge Assessment Board. He was also involved in the South African Moving and Handling Project. Welcome.
Thank you so much. I hope I'm audible enough. I think the concept Ubuntu itself explains that indeed a person is a person through other person. And I think it resonates very well with the NHI and Universal Health Access. In this model that we have, we would like to provide solutions for NHI and how it is going to be implemented. More especially because already the minister has indicated the gaps that we have in the training of our nurses. So in this model, we emphasize the role of the community. And in everything that we do, we involve the community using 4 E's. The first one being to engage the community. We will not be able to implement NHI if the community is not involved. So we have to try to put NHI Act into chunks and engage with the community so that they can all know what NHI is all about and be able to help us and assist us when they already have an understanding. The second E that we have in Ubuntu community model is empowerment. We empower the community with information with the main aim of enabling them to be able to make decisions and also to lead in those decisions that they would have made. And in that process, we emancipate them. So for me, I really think it's important that we go back to the communities and continue to talk about NHI so that they can have an understanding. And it is also very important to look at the resources that we have. We are complaining about the issue of human resource, but we know that we have got a large number of nurses and doctors that have retired. What we think that if we bring them back as torch bearers in communities to help by educating the communities, we will be able to get the communities that are empowered and are able to provide or to take care of themselves, thus avoiding diseases, and that is part of what primary health care is all about. So if we strengthen the preventive promotive model, that will help us. And as far as nursing is concerned, I think it is it will be very important that we have money or budget ring-fenced to upscale or to upskill nurses who are currently employed, so that they can be able to understand primary health care and move from the curative care. So we need to change mindsets, as we have already had. Registration, contracted providers. And I realized that in all that, there's nowhere where I saw that our traditional birth attendants and our traditional health practitioners are listed. Or when I look at how do you qualify to be registered, I realize that they will not be able to meet some of the requirements that we are requesting, because we are still a monolithic healthcare system. We are looking at modern medicine. We still have not incorporated indigenous knowledge system. So I also call for pluralism in our healthcare model. I think I heard our minister talking about us having an American system. And I think that if we are in Africa, and South Africa more especially, research has shown us that 80% of our people still go to the traditional health practitioners before they come to us. So, it seems like we are turning a blind eye on that, but that is the reality on the ground. So I really think that we have to also look at that and see how we're going to incorporate that in our implementation of the healthcare system, of the Act as it is now. So I wouldn't want to continue to labor much on this. I think some of the things we'll address when we talk,
Historically, it was very underfunded. You know, one of the things that actually helped with that was a television program. There was a weekly program came out, a fictitious program. It wasn't based on reality, but it was all about the emergency ward within a hospital. Some of you might remember it. It was called Emergency Ward 10. And what that did is it increased the popularity of the emergency system within the general public, the awareness of it, if you like. So making it a nice place to work, or seemingly a nice place to work. She also mentioned about new models for service delivery as being required. Now, I have seen some of the hospitals around South Africa, and it goes without saying that some of the service delivery is, forgive me here, appalling. For instance, one of the things that I see regularly as I pop into various institutions is a patient who can't move themselves. And what happens? A nurse either side goes underneath the armpit and picks them up and starts carrying them around and putting them onto chairs or putting them onto beds, or dragging them up a bed to get the head under the pillow or whatever. You know, that's actually illegal to do in the UK. It's illegal for a nurse to physically pick a person up. How on earth do you move somebody if you can't physically pick them up and they can't move themselves? Well, we've got safer systems of work in place that allow us to do that. One petite 50-kilogram nurse can lift a 200-kilo man on her own, using the equipment that we have in place. You might think that might be expensive to put all these systems of work in place, but how much are we saving? Not only on, how would you put a price on dignity, for instance? That's impossible. But what you can put a price on is things like the cost of diapers. We put a diaper on a person for the simple reason that they can't get themselves to the toilet. And our nurses can't physically carry them there. So they wear a diaper. How much are we spending on diapers in South Africa? they're wearing diapers, they're going to get urinary tract infections. That's part and parcel of the whole thing. How much are we saving, or how much would we save on catheters, on antibiotics to treat these infections, if you just have the correct systems of work in place? Now, the UK were very slow in working this out, and they actually took 30 years almost to go from an initial realisation of this to where we are now, where nurses will be disciplined if they're seen picking somebody up physically. But as a result of that, our nurses are well looked after physically themselves. They're not going home tired at the end of the day because they're not physically lifting people up. You know, I often see South African nurses and I'll ask them, would you go back to South Africa to work? I'd love to. That is the standard response. I would love to, but I won't. I can't work. I can't physically work in that environment anymore. It's too much of a demanding job in South Africa. And they come to England to earn their pounds. That was their initial motivation to go to England. But when they got there, they realised they had to spend their pounds as well. So that didn't work out. The only reason that many of them won't come back is the systems of work that's here are too difficult. Now, we need to improve that within the South African system, and it's easy to do, and it's very cost effective to do. You will save thousands per patient because they're getting discharged from hospital earlier, and the whole system works. I'm aware of time, so I'll speed up. The NHS, we still had food rationing. We were broke as a country. You couldn't buy fruit or vegetables. Meat was very, very rationed. Sugar was rationed. You were told how much butter you could use. And that didn't get eliminated until 1954, which is, 6 years after the implementation of the NHS. As a company, Impact Group are aware of the expenses that all of this is costing the country. So we've teamed up with the likes of Loughborough University to make donations as we can. We've recently approached the London Ambulance Service, who've agreed that they'll donate ambulances to the NHI. Now, those ambulances that we have in the UK are very good quality. They're not the little minibuses that you see in the UK, but they're basically hospitals on wheels that go out to people in need. And they've agreed to donate. I don't know the quantity yet, but certainly they've pledged to make that agreement anyway. We've also got what we call the Dr Mathabo Memorial Initiatives. Now, I'm sure many of you in the room here are aware of that name.
Yes,
of course you are, yes. Actually, Sandra Cephalaro was supposed to be here today. She is the sister-in-law of Malefi. Unfortunately, she had another death in the family this week, and so she couldn't get here today. But through the Dr Mathabo Hlahane Memorial Initiatives, we've got education systems in place through Loughborough University, who we intend to link with Wits University because of the link with Malefi through Wits as well, to educate medical staff in the art of moving people safely. That's just one of them. We've also got an orthopaedic hospital. Fortunately, like I said earlier, it took us 30 years to get to where we are now. South Africa's got this opportunity of being the first country in the world to implement this from the get-go. The United States recently started it. Germany does it, Australia does it, all of the European countries do it, as well as many of the Asian countries. Like you saw on that map that was coloured in red, nearly all of those countries have got a specific safe patient handling initiative introduced within the countries. Now, if you can implement that right from the get-go, then I'm confident that financially you'll see the benefits, but maybe more important than financially, the people that we're looking after will see the benefits. No more dislocations through dragging somebody using their arm. No more skin tears on people who have got steroid damaged tissue because of the other treatments that they're getting. No more broken bones through lifting people with osteoporosis via their armpits. It's incredible the amount of money that non-safe patient handling costs the system. I'll leave it there now, thank you.
Teachers, especially concerning the provision of comprehensive primary health care.
Thank you, Ms. Mathabo. I think at the core of readiness, in terms of, you always have to begin with the end in mind. So you first think, where do I want to, healthcare to develop? What, the minister showed earlier on was what the private sector pays the most. They have mostly hospitals, which is tertiary care, and specialists. And then when you look at the hierarchy, you have physicians at the bottom. And it is because we have created that in terms of how we have structured our healthcare funding in the past at least 2 decades, where primary health care should be where everybody starts. And community healthcare workers must be at the core of delivery. Now, at the moment, when one wants to render a service, you get trained to render a service, and people want to be remunerated for that, and that's normal. So if we are looking at introducing the issue of community-based care, there has to be a plan of how community health workers are going to be remunerated. And I think that is critical to our success if we want to have a primary healthcare-based healthcare in the system. Otherwise, the current bias towards funding of more secondary and tertiary care in our environment of medical schemes, the law is biased to payment of private health care specialists via what is called prescribed minimum benefits. And this is one of the things we need to resolve in terms of our funding goes up. So I've spoken largely our plan around human resource. Then the second.
Given the speciality of the trade union that you represent, SAMATU, how do you see the trade unions and health professionals formations contribute to information dissemination, advocacy of direct programs, and holding government departments and officials accountable?
Thank you. Minister Mtsali, SAMATU has indicated from the beginning that we are friends of the NHI, and nothing has changed. And we had said that our support is not unconditional. We have a lot of conditions that we've raised, but we think it's better to raise them when we're in. In this transitional phase where we are moving towards the policy, towards protocols and implementation, we want to be there. We don't want to make the same mistake that we have done as doctors, because SAMATU is the trade union for doctors. We don't want to make the same mistake that was made so many years ago, where economists and lawyers control whatever that was there for the doctors. I won't mention institutions, but we're still fighting to get the control back so that we can at least think. We want to avoid that component. There's one thing I need to raise first. The role of a trade union is not that of opposing government or the employer, but to stand for its members. And we think the best way of standing for the members now, during NHI, is to be there. Hence, we declared ourselves to be the friends of the NHI. If we have disagreements, we'll raise them within when we are inside. I want to raise a few issues here, because as the trade union, we we need to mobilize our members to be in support of the NHI. We need to mobilize our members to see the same way we're seeing it. Historically, medical schools are built away from universities, which makes doctors socially, apologies for using the word, dull. We become socially dull because we know nothing except the class, the dissection hall, sleep, cafeteria, class. That's the entire cycle. And we talk about medicine the whole day. And with that, it means that most of the doctors don't want to participate in anything political. And they forget that our lives here on earth is all about politics, whether we like it or not.
Yes.
So our aim is to try and mobilize all our members. But I want to say, people who complain about NHI, forget the other positive things that government has done. Every single specialist in the country was trained in the public sector. Every single one of them.
Yes.
The majority of the specialists who are in the country predominantly work in the public sector. We still have a lot who work only in the public sector. So the other ones also do some AWAPs there and there. The reason they are staying is that, Minister, there's something good that is happening there. It's not just all about the money. Honorable Ramkupa, the issue of paying the skeleton. We think that during this policy design and framework, during the policy implementation and the programs at workplace, including protocols, that's where, as doctors, we're coming in. We need to be responsible of bringing those muscles, blood vessels, the nerves, the tissues, anything that is needed until that skeleton is human and works. It might take us a while. We'll also get, you see, when we live here, the reason I mentioned that the trade union's role is not to oppose government or the employer is because I know when we walk out of here, I'll be told that I'm selling out. So I'm raising this because we want to be there so that we can influence that change, so that the end product should be the years of our input that we put in there. Let me tell you about the painful truth that we
from our esteemed panelists. I just get the direction from our program directors. How are we doing for time? In terms of, can we now move to our Q&A? We're not doing one.
Yeah, we're not sure. We're behind time. Please,
Okay,
let's
we're
move
behind
and
time.
move quickly.
Okay. I think the only one other topic that we wanted to address also, what now would be AI and NHI, but I think one of our panelists was unable to attend. So I think what we'll do is that we will take 1 or 2 questions. Is that fine? Yeah, 1 or 2 questions and then limit to that and then round up the session. Do we have any hands? I see 1 at the front and 1 at the back. Okay, if we can have those 2 hands in order, please just state who you are, no preamble.
I thought it's my job also to inform, and I want to talk about 2 issues here. The first one, I want us to be practical. We are all Africans, I know, and to feel guilty that we are dropping our culture and all that, but we have got to be practical and face realities. This issue of traditional medicine is not being ignored. In 2000, the AU declared a decade of traditional medicine in the whole of Africa. That during that decade, we will. You know very well that Zimbabwe was regarded as the first country that integrated traditional medicine into hospitals, etc. 10 years later, nothing has happened in that decade of traditional medicine. So in 2010, the World Health Organization African region, we met in Cote d'Ivoire to discuss this issue. Yes, he was an MEC, I took him there. I took 3 MECs. This issue was discussed, and they said there are 3 problems with it in Africa, which we are not able to resolve as a continent. 3 things. Number 1, we are not able to determine who's the practitioner. Nobody has been able to define that. Who is the practitioner of this traditional medicine? Number 2, we are not able to determine the practice. What is it? Is it using roots from, yes. In other words, what do you use when you call it traditional medicine? What is the practice? What was the third thing? There were three. Basically, you were there, please, and you are younger, you can remember. It was the practice, the practitioner. Yes, to determine the practitioner. And then they called all these experts. Leave us alone. You can't, you know. Now, if we have to say we are registering people, because even up to today, I still don't know when we are asking the ones who are in this group. They sue each other every day, they kick out each other, they write letters and say this one is not a traditional healer and all that. So I'm not talking ill of the system, I'm just saying it's complex. And we need to solve those complex things first before we can come and say this is our system. The other one I want to answer is about cervical cancer. Doc, I understand your emotions. It is true. It is true about the cervical cancer that some within 2 days and all that. I did not want to give names. If you move from here where we are, it's not very far. There is a private hospital there. It has got 57 gynecologists. 57 in that one private clinic. Why is it important for me to mention? Because the number of gynecologists in Mpumalanga, Limpopo and Northwest added together, they don't amount to 57. So we are running a system where one clinic can have 57 specialists, when 3 provinces do not have them. So you'll never match them with that. But fortunately for cervical cancer, the World Health Organization has moved that we must not try to treat cervical cancer. We must remove it. We must bring it to an end. So just like in HIV/AIDS, they came with 95, 95, 95. The WHO came with 90, 70, 90. And we are about to launch it. It's going to be launched officially for countries which are participating, South Africa and Indonesia. We sponsored that resolution. What does 90, 70 means? The first 90 is that 90% of young girls at the age of 10 or so must be vaccinated. That's the way to fight cervical cancer. The manner in which that efficiency of doing a biopsy and all that, even if we reach that efficiency, we'll never deal with this problem. It's too big for that. They say start with vaccination. Fortunately, we have got an HPV vaccine. I don't know what percentage we are, but we have now reached 6 million young girls who have been vaccinated since 2014. That's the first 90. The second 90 is, not 90, 70, is that screen 70% of women. All of it, just ordinary screening, and they describe it there. And I'm confusing things, sorry. It's 90, 79. The first 90 is vaccine, right? The second one is screening. Screen 70% of adult women. I don't know whether we'll reach there. Screen them and see if you have got cervical cancer or not. And the last 90, the middle 70 is the treatment you are talking about. At least if you can treat 70% of women who are diagnosed to be having cervical cancer. If you combine this 90, 70, 90, they say we are likely to eliminate it. And that's the direction in which we are moving. Now that direction will be impossible if all the money is put in one side. Only the women in this 14% will get these things. The others won't get them. And we'll be back to square one. Thank you very much.
Had insights into key critical steps towards universal health coverage. Thank you.
Thank you very much. What she didn't say is also time, because I have something else. But thank you very much for agreeing to swap, and greetings to all of you. But maybe a special greeting to Tsepo. And I call her Tsepo, First Lady. She drove me somewhere. And I was skipping. She didn't know I was skipping. But, so we have a nice story between us. But TG, greetings, and greetings to all the participants. Well, universal health care, obviously we have to have it. It's not an option. It's something that we must have. And we've been working towards it. And we must get to it now. Access to quality healthcare by everyone, and not just curative, promotion, health promotion, prevention. Curative is a small part of it, in my view. But you must receive it when you need it and where you need it. Because it doesn't help to say there is, but you have to travel 200 kilometers or even 50 kilometers. So you must receive it in your neighborhood when you need it. And then, obviously, if your neighborhood is not equipped, then you can be moved somewhere else without financial burden. Now, without financial burden may also mean transport. Because if you can't get it to where you are, and then you have to pay 200 rands to get to it. If you don't have it, what do you do? Means. But if there is at least transport, if there is no facility in the neighborhood, but there is transport available to take you there. So for me, all those things really matter. Because if you get the 350, and now you have to spend 100 of the 350 in transport, trying to look for healthcare access, it's a problem. So, of course, without financial burden, so NHI comes in. But let me say, as president, somebody called Thomas Sankara. Some of you may know me from Burkina Faso, a small country, once said about health. Health is not just a medical issue, but a political one, because it is a reflection of our commitment to the well-being of our people, close quote. Now, well-being is broader than health. Well-being means I must have proper food to eat, proper nutrition, healthy food. That's part of well-being. Well-being also means, as the doctor there from the panel was saying, clean water, access to clean water. Well-being also means education in my book. Not just health education, but general education, and then health, public health education as well. And we know that children and babies of educated mother have better health. There is also NH. Because if we had proper shelter with NH, we wouldn't be opening pens units with the kills in them. And of course, infrastructure is obvious because we can't be in tents in that picture like the minister showed. So infrastructure is also part of that well-being. But of course, moving from well-being to now health, it means properly trained health workers in enough proportions or quantities to be everywhere. We forget that primary health care is free. Why? Because the services in most primary health care facilities, a lot of them don't have doctors. So a free service that is not quality, people forget it exists. And it doesn't matter to them because it's not providing the proper. And that's why we thought training more doctors would at least help to improve the quality in the primary health care facilities, which is already free. So that is training of healthcare workers is very important, not just doctors, but everyone. But compassion is also very important. If you're a health worker and you have no compassion, forget. That facility, ordinary people will say, we don't want to go there because we don't get treated well. So you must be compassionate to the people who come to the facility as a health worker. Of course, equipment is obviously needed. And I agree with the panelists who are saying we can also use technology to improve healthcare. In the first 5 years, we actually experimented with those who were there would remember. We were promoting telemedicine. Then, and then I don't know where it disappeared to. It's somehow got forgotten. Because we were aware that we didn't have enough specialists, we didn't have enough radiologists, but we're talking health today. So I think that's very important. But something I learned also more in the UK, because I was 5 years in South, I trained for 4.5 years in South Africa, but I qualified eventually in the UK. Something I liked about, there are lots of things I like, but I'll just call one. You don't discharge a patient, especially if it's a patient who had a stroke or something, without knowing whether at home they are able to cope. If a person is now in a wheelchair and they were not before, you can't discharge them until you have made sure that at home they can reach the cooking facilities, sitting on the wheelchair and so on, which we don't do here. We just discharge the patient, what is awaiting them at home. Of course, they went further, Bona. If you can't cook for yourself, they have meals on wheels, which maybe is more difficult here. But also maybe different because, Tina, there aren't many people who live alone like they are in the UK. There are lots of people who just live alone, old people. Here, people tend to live with other people, so the meals on wheels are not a necessity here. But there's something I also want to raise, maybe controversial. Maybe as controversial as tobacco. Alcohol abuse. Why do we glamorize alcohol so much? You know, the alcohol adverts, it doesn't say to parents, children mustn't watch this, or you must make a parental judgment. They just show them. So young kids grow up glamorizing alcohol because they see it on our screens. Why? Really, why? And then we wonder when they drink and kill women, kill people on the roads. How much do we spend in health on accidents, injuries? fights, people get stabbed, people get killed. And on the whole, it's usually related to alcohol. And are we happy with that? Is it fine? Is it going to improve universal health care? So think about it. Think about it, and you know, I always just feel so bad watching TV and seeing all this glamorization of alcohol. I wish I didn't have it. Gigi, let's think about it. And then, in the interest of time, I want to say something interesting. The minister, he's gone now, he said our system is like Namibia's. But Namibia is teaching that system. They are looking at public servants, ministers, and everyone using the public health. They are looking at that probably from April next year. They might start. Because it says the money that's being used for medical aid for all these people must go to improve the public health service. And also, if we all are forced to use it, we make sure it works. We make sure it works. So, some good things are happening on the continent. And I really liked that idea that the President of Namibia is introducing. But let's all use the public health. And if we all did that, we'll see what happens. It will improve. Because we know that it's not only us. Our children are on our medical aid. So if there's no medical aid, they also are part of using the public health service. So, but I just thought I should say it because the minister said our system is like Namibia, and I'm saying Namibia is teaching it. For government and for all of us to understand that it's not the Minister of Health alone and health workers who can improve the health of the nation. If people are starving, their health is not. People are drinking dirty water, and so on and so on. So it's a collective effort that will make the nation healthy. And if the nation is healthy, you'll spend less. You'll spend less in hospitals. I mean, you saw during COVID how less the injuries, egg wounds, and all those things disappeared because alcohol was not being glamorized at that time. It was not being sold 24 hours. But that's a story for another day. So, all of us, the entire cabinet, is responsible for health in a way. In fact, when I was Minister of Health, I was surprised Sri Lanka at the time had the Minister of Health and Highways. Yes, that was his title, Minister of Health and Highways. Because highways were creating problems for health. So they put the two full portfolios together so that the Minister of Health must see what needs to be done to make the highways safer. So, in the interest of time, I won't go too much further, but let me just say that the minister also talked about Ebola and how South Africa got there before the big countries. There were no big countries that got there. They got there, America did the treatment centers with nothing else. The British brought their big ship, maybe ready to evacuate their people. I don't know. How Ebola was resolved was Africans came together. That's one thing where Africans were united. We got more than 800. We asked for health workers. I was at the AU at the time. We asked business to support. Business supported us so that we could look after the 800 plus health workers who volunteered to go and work there in those 3 countries. The countries themselves paid those health workers at home. We looked after them when they were in those countries, accommodation, transport, food, whatever. That was an example of how a united Africa can work and defeat something without much help. The Cubans helped us. They brought about 200 doctors, medical people. But generally, the continent dealt with it itself. There were more than 800 health workers from different countries that went to work there. And President Obama at the UN in a side event had said, if nothing drastic is done, 1.4 million Africans are going to die. Not less than 100,000 died, less than those who died here for COVID died in all 3 countries combined. Why? Because Africa came together. It shows the united, we don't need some of the aid that they are taking away now. Business people helped us, MTN, Patrice, other countries' business. The first day we invited them at the AU, we got $30 million US. Then later, others came and gave money. But also the telcos. We asked the telcos who were willing to do it, to send SMSs to ordinary people saying, if you respond to this SMS, you donating R1 to the Ebola, or you donating $1 or whatever. And some of the telcos did that. And we did get money. So I'm just saying, the Ebola, there were no big countries. I was just wanting to say that. China helped us a bit. Cuba is not a big country, but they gave us the most help. And to conclude, fortunately, none of the African health workers got Ebola. They were led by a Ugandan general. We chose a Ugandan general because Uganda does have Ebola outbreaks from time to time, so they understood it. But what was interesting about the Cubans, one Cuban got Ebola, he was evacuated, and he was treated. And he said, I'm going back, the task is not done. And he went back. How many of us would do that? Thank you.
will happen to them. So that's under strengthening the health system. There are various other things that are going on, and I'm sure you see them from time to time. We don't get much media coverage unless it's bad coverage, but there are a lot of really positive things going on. In terms of legislation, of course, there's the Act. The regulations were published 3 months ago. Next week is the end of the 3-month comment period. There have been 898 comments received so far. Some of them are just rude comments, where, as people did during the Act, where they just send out a mass mailing list. But there are some very constructive comments, and we will start to integrate those comments into the draft regulations from the 7th of June. We've given ourselves 1 month to incorporate those comments, and then we will approach the President to proclaim certain sections of the Act to enable us to implement at least sections 12 to 30, which will mean that we will have the governance structure in place. But there's a whole range of other sections which will come into effect at the same time. We also have been busy for 1.5 years with the Competition Commission on trying to regulate the prices in the private sector. Many of you will know the history. In 2008-9, the Competition Commission ruled against the regulation of pricing in the private sector. We've had this void until the health market inquiry, then COVID got in the way, and now since then we've been working with the Competition Commission to find alternative ways that are legal for regulation of pricing in the private sector. We've been informed last week that the same parties who've taken us to court are objecting to anything that will regulate their prices, and are going to take us to court on those as well. So we met with the Competition Commission earlier this week, and they will continue to engage with those people, and we will continue to engage with them. The third of the 5 activities that are prescribed in Section 57.2a is the establishment of institutions that will be foundational for the implementation of national health insurance. And there are 2 primary institutions that we are busy with at the moment. The one is that on the Minister's desk at the moment is a submission for the appointment of the Ministerial Advisory Committee on Benefits. A lot of work has been done, but now it's got to move into that advisory committee, who will set the framework in place for the permanent advisory committee, which is a statutory committee of the Act, which will come into place sometime towards the end of this year or early next year, if all goes well with our implementation. The second one is on health technology assessment. And what health technology assessment is attempting to do is to make sure that there's evidence for the choices that we make in what we include in a package, whether it's the benefit itself or whether it's subcomponents of the benefit like medicines and devices and so forth. In that health technology, we've been working with the NICE, which is the National Institute for Clinical Excellence in the United Kingdom, for the past year, as well as with the Philippines. And we now have the technical working group has put the mandate together for the appointment of the Ministerial Advisory Committee. That's also in the Minister's office at the moment. The fourth of the 5 interventions is on vulnerable populations. So the main issue here is to make sure that we start putting the primary healthcare integrated system in place. So Prof. Musa spoke about what they've learned in Chiawela. There have been other institutions and other activities that have been going on. And in fact, we've now recruited him from the 1st of July as part of our team permanently. So he'll move away from Gauteng. Thank you for letting him go, Gauteng. And the team is getting bigger and stronger, and we are now working very solidly in all 9 provinces, including the Western Cape, on contracting units for primary healthcare, where the capitation package, in fact, yesterday we spent 1.5 hours with the World Health Organization head office talking about the packages, and the day before we had a workshop with Wits University's price list, where we are looking at exactly how to go about the pricing. There's costing and then there's pricing, but it's sitting physically being managed by the CSIR for us. We need to move all these things into the fund's ambit, and to do that, we need to operationalize the fund. So sections 9, which establishes the entity, 10, which gives it its functions or its mandate, and 11, which gives its powers to start employing people. Now, that is what these first set of regulations are focusing on. We hope to have the board and the advisory committees in place by the end of the year. We've put very transparent processes in place for the recruitment of these bodies. And then the board must recruit a CEO so that by April, May next year, we should have a CEO for this organization. That's at that point, we can start using the Labour Relations Act, Section 189, to transfer the handful of staff that are currently in the National Department of Health into the fund as employees of the fund and transfer the assets and start really building the administration. Last comments I want to make is that while this is going on, we are preparing for phase 2. You don't wait until you finish with phase 1. Phase 2 will catch us. It will come at the end of 26 as we move into 27. And that's the point at which Section 49, which is the flow of the money, will come into effect. Remember this fund, there's no NHI fund at the moment. There's no NHI. All the money that people in Parliament are stamping their feet about is all health system strengthening. The money needs to come into the fund through the provisions of Section 49 for the fund to start purchasing healthcare services. That will happen through the budget process. And what it says in Section 49 is that the first call on that money is conditional grants, provincial equitable share, and monies that are sitting in other government departments, for instance, correctional services. And that needs to be planned carefully and sequenced so that when the services are purchased by this administration, that's all in place. So we're busy with that, and it's got lead time attached to it. The second part of that funding is the tax credits. The Minister spoke about it, 34 billion rands worth of tax credits. If we remove the tax credits from people who earn over 1 million rand a year, we would bring in 7 billion. Now, if you're earning 1 million rand a year, and many people have got spouses who are earning another million in that same household, if we take away 340 rand per person from your household in a month, it just means you can't go to the Spur for breakfast once a week. Or once a month. That's the value of money that you would not see go, and we would put 7 billion rand into the national health insurance. So that's the kind of discussions we're having. We want to get that into a fund so that we can use it to get the capacity running and start making payments in primary healthcare space. My very last comment, because you want to wrap up, is that amidst all of this, I spend 50% of my time with lawyers, dealing with court cases. And the content of the applications against us is frankly pathetic. Thank you.
In ensuring that this, what they are doing actually is implemented against the wind that is blowing in our country. Thank you. So I'm going to summarize some of the key insights from this colloquium and highlight some of the essential points that are critical. Of course, the meeting was officially opened, introducing key leaders and policymakers, which is good, which means that all this discussion is going to the right place. And the goal that we're told was to unite the stakeholders in the health sector to discuss the national health insurance and address the anxiety surrounding some of the work that is being done. I'm not sure if we've achieved that, because when I listen to some, I'm not sure if they're buying in. But most of the people that are here are buying in. So that's good. It's making progress. Thank you. If you have shifted, please withdraw the case in the court. They emphasize that, this room emphasized that policies must engage society inclusively, ensuring continuity of healthcare access across generations. So it doesn't end with us. It continues beyond us. On the question of challenges and inequality in our South African healthcare, we have to deal with the question of persistent inequality in healthcare access due to problems of socioeconomic status. Of course, race is another issue. Medical schemes only serves a fraction of the South African population, leaving the majority reliant on the public healthcare system. And that is what NHI is dealing with. We heard that there is still continuing a quadruple burden of disease of HIV, TB, cardiovascular diseases, and maternal and child health. I would also say COVID. We need to add COVID because it's still there. We just don't pay attention to it. We have it. There are new strains that keep coming. We still need to wake up to it. And the high cost of healthcare limits accessibility. That is what I heard. The other thing that I heard, which is really of concern, and it was also said in the video by the President, that misallocation of healthcare funding favors the private sector, which in a sense worsens disparities that we're experiencing. On the question of framework and implementation of NHI, we heard that the NHI Act serves as a foundation requiring system enhancements and partnership for successful implementation. We heard that we cannot do much without working together. And I'm asking SAMA to join us and work with us for our people. We all need to do that. The country must recalibrate funding flows, conduct cost analysis, and prioritize access to essential services. We heard about comparison with the Thailand system, which successfully addressed economic and healthcare challenges. So that is something that we have to do as we implement NHI. We're also told that we need to address the key areas for effective NHI implementation, that the NHI financial structure must work out in such a way that we end the imbalance between the public and the private sector funding. If we end that, we'll be able to ensure universal access to healthcare coverage. On technological integration, we heard that we have to focus on the AI and digital systems to improve efficiency. We should no longer be going to the next person sitting next to us and say, what does that mean? We must go to AI. AI should be our friend, should always be in our pocket, very, very close to us. Pick up a cell phone, you look at it, you say, what do they mean by this? You get all the information that we want. We need that, especially as we start implementing NHI, because it could speed up the implementation. And on the debate over the mandatory versus voluntary prepayment models, so that people understand exactly what that means. Many people will tell you, I still need my medical aid even if there is national health insurance, because they don't understand what national health insurance is going to do for them. And then, of course, there is a big problem of concerns about funding shortages because of the global health initiatives that are really suffering. Some of them, as you heard, are going to be bringing those offices here in South Africa and many other places. Let's use that opportunity to learn from them, to get international experience into our own system in the country. On the NHI benefits and actionable steps, financial protection is said to be very critical so that we don't bankrupt people because of the fact that they cannot pay for health services. There is a need to test the new payment models to enhance efficiency, and also we should define services covered under NHI to ensure transparency. That work that you say the department is doing with regard to the benefit package needs to be accelerated and shared widely, because it will remove this fear of, will I still be able to get healthcare in the country? Because some of the concerns people have are real simply because they don't have information. Once they have information, they may change their mind. And of course, ensure community involvement as a key principle to ensure success. On health system strengthening, the issue of our traditional healthcare practitioners, we heard what the minister said. I will not repeat on that. On the themes and core objectives, the NHI, remembering that it's a human right, ensuring this universal access to healthcare, where healthcare does not solely benefit the rich, is key. And that standardization and inclusivity is key. The NHI aims to guarantee equal access to healthcare for all citizens, including foreigners as well as children. And with foreigners, they have to come in with their own insurance, and they can be able to get emergency services if the need arises. And address the co-payment issues, because it's very clear, because healthcare is very, very expensive. On the NHI development and implementation challenges, we should look at the historical context, understand that we started in 2007 that there should be NHI. People are waiting for it. So let's gallop and make sure that it actually happens. It's very critical for us. And then on conditional grants that are going to be given to provinces with money that's unused, which ends up going to Treasury, raises concern. And that is something that we have to deal with if we're going to implement NHI effectively. And of course, the new system under NHI will require centralization and the money going in straight to the districts and to the facilities to make sure that funds are actually spent by those facilities. And then on the proposed solutions and role of technology, we talked about digitization of healthcare, that the Health Professions Council must act in line with the National Health Policy and make sure that they support NHI through digital record keeping and harmonized regulatory tools. On community-based care, we should involve community health workers in equity-driven models to ensure populations receive comprehensive care. The private practitioners and NHI, will private practitioners continue under NHI? Of course, they will. The Health Professions Council of South Africa must align with government policy, that's what we had. They must regulate the healthcare providers accordingly. And of course, they should be using the capitation model. And it was a good discussion about capitation itself, how it can actually be implemented. What is it and how it can be implemented. But we must address some of the challenges that doctors are having, the trust that government has with regard to payments. Contracts must ensure reliable reimbursement. So consultation should happen with the doctors so that they can understand how they are going to be paid. Because the bottom line is that they want to know, will I be able to get my pay when I want it? Because currently there are some problems in some provinces where money is not paid quickly according to the contract. And then of course they are concerned about workloads. Progressive doctors are emphasizing maybe you should go for health promotion in order to reduce the demand rather than just to wait for acute care patients that need to be taken care of. And then change, of course, the healthcare approach. Treat populations rather than just individuals so you can cost effectively and provide quality healthcare. 2 more points. Medical schemes and regulatory role in the NHI. Under the NHI, medical schemes will see reduced revenue. Of course, it will lead to consolidation and complementary coverage rather than full healthcare provision. And then there will be a need for regulatory oversight, and the Council of Medical Scheme will support the NHI policy, ensuring equity is maintained and transitioning away from healthcare as a commodity. Then on final considerations, South Africa must ensure fair allocation of funds to improve public health care. The NHI should adopt a single-payer system for efficiency. The trade unions and medical professionals should collaborate with government to refine policy execution, not to refine the Act. The Act is passed, but in terms of execution, they need to come on board. And doctors advocate for self-governance, avoiding excessive administrative control. We should address their concerns with regard to that. And there should be agency in misallocated of resources. In conclusion, we heard about the equity in access, that NHI is going to prioritize affordability and fairness for all South Africans. On efficient resource management, the government must ensure financial and healthcare resources are deployed effectively. And of course, there should be an integrated approach where NHI combines primary healthcare technology and community-driven models for success. And working with the private sector is also key for success of NHI. And the law does say exactly that it's going to be happening. Thank you very much.
Alpha, yes. That is emerging. And they respond differently to children. So we need one another, intergenerational, multi-skill, multi-professional and all that. So thank you very much, Mama. Your wisdom will help the MECs that are here. We are there to support you. The private sector that's here, you are part of the society. The Mandela moment was about using the diversity to achieve common goals. And we hope one day we will agree that health is a human right and not a commodity. Because in economics 101, a product or a commodity that is efficiently dispensed in a free market system should not have certain characteristics. One of them is that it should not be a public good. Secondly, you should have choice. Customers have choice. Do you choose to have Ebola? No, you don't. So economics 101 really says the health doesn't belong here. That's why the prepayment, the universal health. So if we can just agree on the basics, there's no need to go to court. And we will, as PBF, we will take very, very closely to our hearts the communication between the minister and the largest health medical professional association. We need to find one another. But be comforted. Even in the national health system of the UK, the doctors were made to feel afraid of this now new health system that is universal health coverage. But when in 2012, when the Conservative Party wanted to remove it, it is the health workers, health professionals that defended it. So it shows that if we give ourselves time to listen to one another, it is possible. And I also believe, so all those in the medical aid system can be of use to a universal health coverage system. We need one another, we need all hands, we need multi-skills and all that. Have we achieved our objective? We have unpacked the NHI Act. We have looked at its implications. We have also understood its future direction in terms of implementation. We also have focused on its implication on population wellness, health system strengthening, and stakeholder participation. As we celebrate the 25th of June, which is the 70th anniversary of the Freedom Charter, we can now say there shall be houses, security, and comfort, and that there will be a health system that works for all South Africans. Thank you very much. This is the inaugural series, the inaugural colloquium of a series of 4. We hope to see you when we now look at beyond understanding in the much more implications, and we hope we will be more together than today. Thank you very much. Be blessed.